Good evening, everyone. My name is Wendy, and I'm a community education coordinator for Boulder Community Health. Before we start, I just want to remind folks that they can get the latest COVID-19 vaccine information on our website at bch.org. Additionally, Boulder Community Health's 3 urgent care centers now offer a highly accurate test that can check for both COVID-19 and flu viruses at the same time, returning results in about 20 minutes. Appointments are required, along with a video visit prior to testing. BCH urgent care centers are located in Erie, Gun Barrel, and Superior. You can learn more about this at bch.org/COVID testing. So I'd like to welcome you to tonight's lecture on innovative treatments for painful hips and knees. I'd like to go over the format for the lecture. The lecture portion will last about an hour, and then afterwards we'll use the remaining time we have for questions. Please type your short general question in the chat box to the right or at the bottom of your video screen, and we'll take as many questions as we can as time allows. So on behalf of Boulder Community Health, it is my pleasure to introduce this evening's speaker, Dr. Clint Brian Blackwood. Dr. Blackwood is Boulder and Longmont's only fellowship-trained hip and knee replacement specialist. He has successfully treated over 4,000 patients with hip and knee problems and has performed over 2,000 robotic-assisted surgeries. He was the first surgeon in Colorado to offer Mako total knee replacement. Dr. Blackwood sees patients at Boulder Center for Orthopedics in Boulder. So please welcome Dr. Blackwood.
Thank you all for joining us online. It's a little odd to be talking to 2 people in person and upwards of 800 people online. So you are in good company, and we look forward to educating you, a little bit of entertaining, and hopefully answering some of the questions you have that come across. So feel free to ask those throughout the program, and we'll look forward to answering those at the end. Like she said, my name is Brian Blackwood. I work at Boulder Center for Orthopedics here in Boulder, Colorado. I'm the medical director of the joint program at Boulder Community Hospital, and I look forward to educating you tonight. I grew up in Montana, went to a small school there, played football, then transitioned to the University of Washington out in Seattle for medical school. Did my residency at the University of New Mexico in Albuquerque in orthopedic surgery, and then did a fellowship focusing on minimally invasive surgical techniques combined with advanced robotic technology at the Kuhn Joint Replacement Institute in St. Helena, California, under the guidance of Tom Kuhn and Adam Friedhand. I was actually the first surgeon with fellowship level training specifically in robotic arm assisted joint replacement, and that led me to where we are today here in Boulder. I have medical licenses in Colorado and Montana, and I am a consultant for Stryker Robotics on the education portion. I actually go around and train other surgeons throughout the country, or they come and observe surgeries here in Colorado in this new technology. I've had a long history with Boulder County, even though I grew up in Montana. That little guy behind the cow is me approximately 30 years ago, winning blue ribbon at the Boulder County Fair for showing that heifer. My grandfather had a ranch outside of Longmont, a small hobby farm with some cattle, and so I would help out during the summers with hay and raising the cattle. He was a dentist in Longmont for more than 30 years and retired into being a farmer. He and my grandmother both passed approximately 10 years ago. But the family has grown significantly, so these are my 5 children. We went for 4 and ended up with a bonus at the end. So most people are excited just to see the updated pictures of the children as they grow through time. It is a little bit of a circus at our house, but we do manage to squeeze in some fun and enjoyment. All 5 of the children are currently with my wonderful wife, who is helping take care of them and getting them ready for bed. So we appreciate the time and effort that she puts into making the family run. A little bit more about the practice. My surgical practice is focused exclusively on hip and knee replacement. It's focused on minimally invasive surgical techniques combined with advanced technology with the goal of giving patients the best outcomes that we can. 99% of our cases are done under a spinal anesthesia. Our average length of stay for total knees and hips is both 1 day, and more patients are leaving the same day. 90% of patients are able to be discharged directly to home with outpatient physical therapy and don't have to go to a rehabilitation center. And for the last year and a half, we've been doing surgery at the Boulder Surgery Center, doing outpatient surgery center and having patients go directly to home and have the robotic arm assistance at this facility as well, the only one in Colorado. Boulder Center for Orthopedics has the lowest complication rate for joint replacement in Boulder, in the city proper. We merged approximately 5 years ago, Mapleton Hill and Boulder Orthopedics, to form Boulder Center for Orthopedics. We have hired new partners. We're expanding, and I think it's a great place to work and a great team. And our goal, again, to give high-level care to the community here in Boulder and around the surrounding areas. I want to just kind of start with the basics of the talk and what the most common causes are for hip and knee pain as we age. As we get over the age of 50, the most common cause is arthritis. But what is arthritis? What's causing these pain in the knees and hips? As we grow, we develop smooth, healthy cartilage, which is great for joints. It's very low friction. There's no pain fibers in cartilage. But as that starts to wear away, it exposes the bone underneath. And there's a lot of pain fibers in bone. So that causes a lot of pain, discomfort, inflammation, swelling, and difficulty with our ambulation and mobility. Osteoarthritis is the most common cause of the two main types of arthritis. This is where that cartilage wears out, exposes that bone underneath. This can happen in the setting of inflammatory arthritis, or inflammatory arthritis can be entirely separate. Inflammatory arthritis is a systemic process, such as rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis. And this is where the body turns against itself, and the body's normal immune system starts to attack the normal cells around the joint. This can lead to degradation and pain, swelling around the joint, and can cause discomfort. Luckily, we do have pretty good medical treatments for inflammatory arthritis, so we see fewer of these patients, but that is still an issue that we see today where these inflammatory arthritis patients also need joint replacements. This is what arthritis looks like on the x-ray. On the left-hand side of the screen, you can see there's no space between the bones. On the right-hand side, you can see there's space between the upper and lower bone. That's where the cartilage is at, and so that's where we get the term bone on bone. Once that cartilage is gone, the bones start rubbing against each other. This is also why we like to get x-rays with patients standing if we can, so we can have gravity in the picture, so we can actually look at if there is space still while patients have gravity involved, then they usually have good cartilage left. If they don't and the bones are touching, then that's a significant and severe arthritis. It doesn't have to be as severe as in that last x-ray. It can be just isolated to the inside part of the knee or a single compartment. But this still causes pain and discomfort for patients and leads them into our clinics. Hips, similar, have a nice smooth cartilage. It's a ball and cup joint, gliding joint, very good for ambulation, but hips can tend to wear out fast. If the cartilage in the hip starts to wear out, it throws off the whole system and can have a rapid progression of arthritis. Knees, people can know they've had bad knees for 10, 20 years. With hips, the most common thing that I've heard is it's bothered me for about a year or two before patients need to have their hip addressed. So the progression of arthritis in the hip is significantly faster than on the knee side. This is what that looks like on x-ray. Again, the right-hand side of the screen showing a relatively healthy appearing hip with good space between the ball and the cup here on the side. On the left-hand side of the screen, significant severe bone-on-bone arthritis. It's actually starting to form some bone spurs on the inferior part of the acetabulum and the femoral head and causing significant stiffness, pain, and dysfunction. There can be other causes for hip pain. The hip joint itself is more in the groin, but a lot of people will complain about hip pain that's on the side of the hip. It hurts if you lay on that side or sleep on that side. It can come on rather acutely. So if that's the case, it's often bursitis that's the problem. You are allowed to have bursitis and arthritis at the same time, but if you don't have arthritis and just have bursitis, that can be treated without surgery very consistently. Back pain can radiate down toward the hip and cause hip-like symptoms. It can radiate around and mimic the symptoms of hip arthritis. This is why we like to get x-rays when you come into the clinic, do our physical exam, sort of evaluate fully if we can. And then there are other rare complications, rare causes of sort of groin pain that can mimic hip pain. And a hernia is one of those where there can be pressure on the groin area that mimics the pain from the hip. Again, we do our full physical exam, examine the x-rays to help differentiate between these causes. Unfortunately, you are allowed to have more of these at a time than one at a time, so patients can have back pain and hip arthritis, they can have bursitis and arthritis, and they can have hernias and arthritis. So we just try to address the causes as consistently as we can. The number of patients needing hip and knee replacement is increasing significantly. It appears to be increasing a lot this year as well. This so far has been the busiest year that we've had as people have come out of the COVID precautions and are getting vaccinated and ready to proceed with getting their hip and knee replacements taken care of. The number of these has been projected to increase for the last 15 years and is projected to increase even more significantly in the next 15 years, up to about 3.5 million knee replacements and upwards of 500,000 hip replacements being done per year. Interestingly enough, Boulder County has the highest per capita hip replacements in the country. I think that's because we have such an active population, and unfortunately, too many miles wears out the hips, unfortunately. Patients are getting older. They're younger and older. They have different expectations. Unfortunately, we have patients who are teenagers who need to have their joints replaced. We have patients in their 90s who are still doing well health-wise and need to have their joints replaced. Everybody wants to maintain their mobility, to have an excellent quality of life and active lifestyles. Patients are better informed today. They're listening to lectures such as this. They're checking out information on the internet. They're talking to their friends. Beware of the internet. There's no quality control on the internet, so we can't really do fact checking as we go through some of the claims that are placed on there. I bring this up specifically in regards to stem cells, which we'll talk about a little bit more, but there is a lot of promise and things made out there that don't necessarily have the execution and performance that they need to back up the claims that are being made. So. But we don't necessarily want you to jump straight to having your hip or knee replaced. We try to delay or avoid that if we can. So how can we do that? Treatment options for hip and knee pain as we start, usually sort of rest, ice, sometimes some heat applications can help with the hip and knee pain. Medications for inflammation, just over-the-counter anti-inflammatories, ibuprofen or Aleve can be very helpful. Sometimes Tylenol can help. It's surprising how many patients come into the clinic that are ready to have surgery that aren't even taking any of these medications. Obviously, we don't want to do a high dose of these for a long period of time, and they do have some systemic effects that we want to try to minimize, but they are very good for sort of mild to moderate arthritis pain. Lifestyle modification is important, so avoiding high-impact activities, biking over running, try to keep weight off if you can. Physical therapy can be helpful for strengthening around the joints and increasing range of motion. Joint fluid supplements we'll talk about more extensively for both hips and knees. Knee arthroscopy used to be a common thing for sort of early arthritis. The idea was to go in and sort of just clean things up a little bit, try to buy a little time. That's fallen out of favor over the last 5 to 10 years. So really we don't go in and do surgery for arthritis anymore. We don't try to clean it up and buy some time. There have actually been studies shown that that can make things progress more rapidly, and that even if they do improve for a short period of time, at 2 years, there's really no difference between whether you had the knee arthroscopy or not in arthritis. There are definitely reasons to have knee arthroscopy as an older age if you have an acute meniscus tear, or if you have minimal arthritis and the ACL tear as you get older and are more active. But in general, if there's enough degenerative disease in the knee arthroscopy is usually not a very beneficial treatment. And then total joint replacement we'll focus on extensively. These are the American Academy of Orthopedic Surgeons guidelines for non-surgical management of knee arthritis. In general, we recommend patients have a BMI or a body mass index less than 25. So if you can lose weight, it's actually a great bang for the buck off the knees. And hips, it's 5 to 7 pounds for every pound that you lose. So that helps to offload the joints. Exercise, trying to keep yourself motivated and moving around is actually very helpful. We don't want you to just kind of stay on the couch and avoid motion or mobility activities. Anti-inflammatory medications, like we said, can be very helpful. We try to avoid the use of opioids, though. If the pain is becoming that significant that you need to discuss opioids with your regular doctor, it's best to come in for an evaluation for other treatment options. If you start opioids before surgery, it can be very difficult to maintain your pain control after surgery, as well as it can actually make you have more pain after surgery because of the way opioids affect your brain. And then injections, intra-articular injection options, corticosteroids, and certain growth factors such as PRP, there's some inconclusive data on. These are short-term treatments that are definitely not going to cure the arthritis, but can be treatment options for short-term pain relief with less side effects than from a surgery. But there are starting to be moving away from hyaluronic acid, the visco or gel injections, because there's not a lot of data if you actually get into big studies showing that those hyaluronic acid injections work. So talk a little bit more about these individuals. These are sort of the standard, you can do this yourself. You don't need to come in and see us for these sort of treatments. These are over-the-counter ibuprofen or Aleve, Tylenol. If patients are on certain medications, Celebrex is sometimes a better option if you're on a blood thinner and your regular doctor approves that. There are topical compounds now over the counter. Voltaren gel is now over the counter. So if you can't tolerate oral anti-inflammatories, sometimes that's a good option, more for knee arthritis than hip arthritis. And then glucosamine and chondroitin are very popular supplements. There's not a lot of great large studies supporting their use or benefits, but individual patients seem to have some benefit. So try to recommend the patients, if it's working for you, continue. If it's not, you can take a little break and kind of see if you notice a difference. And if you don't, then it's probably not worth the money for that. Some of these activity modifications, avoiding running and jumping. I'm not overly popular in Boulder for telling people not to run anymore, but we do want you to be active. We want you to keep the weight off. This goal BMI of 40 is the number where you're morbidly obese. As you go above that number, you get increased pain in the joints, and it also increases the complications and risk that you have with surgery. So you have a higher risk for blood clots, higher risk for infections, pneumonias, things like that. And so we want to try to get that BMI as optimized as we can and try to get your weight down as much as we can. We also realize it's difficult if you have a lot of extra weight and severe arthritis to be able to lose that weight, but we're willing to work with some of these non-operative treatments to help you get some short-term relief so you can work on some of that weight loss. Joint injections is one of the best ways that we do that. Usually first line is a cortisone injection. Cortisone sort of has a bad name around the area. There's a lot of people that try to avoid that at all costs. You don't want to do it too often. You want to spread it out and use it judiciously. But it can be helpful for short-term relief of pain and inflammation in both hip and knee joints. Viscosupplementation, we'll talk a little bit more about. These are chicken shots or the hyaluronic acid injections. This was originally taken from the comb of the chicken, which is where it gets the chicken shot name. But now the majority of these that are being used are man-made and made in a lab so that you don't have to worry about allergies to chickens or eggs. These are covered by most insurances in knees, but not by any insurance in hips. And actually the coverage for these in insurances is becoming less and less. Kaiser doesn't use these. Other health insurance plans are not covering these injections anymore, sort of following on that AAOS guideline recommending against the use of these HA injections. I sort of reserve these for patients who definitely don't have bad enough arthritis on x-ray that we think that they need to have a joint replacement and the cortisone injections aren't working, or patients who really don't want to have surgery or really want to try to put off surgery so that they can try to buy a little time. But in general, I try to explain to patients that they're not as consistent as a cortisone injection, and it works about 50 or 60% of the time in most cases, and in severe arthritis, it seems to work less than in less severe arthritis. PRP, or platelet-rich plasma, these are injections of blood products that we try to use to sort of enhance the healing and decrease the inflammation in the joint. This is where we actually draw blood from the patient and spin it down. These are covered by insurance and can be relatively expensive in the $300 to $500 range. There's some early studies showing that this can be somewhat similar toward a cortisone injection. But again, this is not going to cure anything inside of a joint. There are good studies for platelet-rich plasma or PRP in soft tissue, in tennis elbow and hamstring tears and things like that, where it's becoming more mainstream. But in joints, it's still considered experimental. But it's up to each individual patient to decide if that's something they want to explore. The promise of stem cells, so being 10 miles up the road from the center of the stem cell universe in Broomfield at Regenex, it's always good to bring up stem cells and have a conversation about that. The goal here is to obtain these stem cells from the patients or from other fat cells, concentrate them and inject them into the joint to decrease inflammation and promote healing. It's not covered by insurance and is very expensive in the $5,000 to $10,000 range, $20,000 if you want to go down to the Cayman Islands. These individuals seem to think that my future as an orthopedic surgeon is going to be pushed into the dustbin of history, that the stem cells are going to make me obsolete, much like my job at Radio Shack is now obsolete from when I was in college. So I wanted to look into their results and their benefits that they have on their website, comparing their hips and knees to hip and knee replacements for these injections. They referred to this as bone marrow aspirate concentrates. They would try to obtain stem cells from inside the pelvis, and they compared that to total knee replacement, TKA. This Knee Society assessment score is out of 100. So patients who had their total knees replaced were at 48 before surgery and 80 after surgery, so a 32-point increase, whereas the bone marrow aspirate or stem cell group was at 69 before surgery and did increase up to 82. Which is, I know, higher than 80, but it's only a 13-point increase from baseline. And there's no long-term studies about how long this stem cells were successful in improving the mild improvement that they got from the Knee Society scores. Similar in hips, so this hip score is again out of 100. Pre-surgery, patients had a 56 on their Harris hip score. It increased to a 94. Again, in the stem cell group, not quite as severe, and about a little less than 69 on the preoperative score for the stem cells. And again, a 13-point increase up to a little bit more than 82, which is much less than the 94. So patients do very well with hip replacements. It's a very straightforward recovery for the most part. And so I think that this shows clear evidence that hip replacement is better than stem cells, especially in the hip joint itself. So, and this is from the actual data on the website supporting the Regenexx stem cell website. In some instances, I think the best analogy for stem cells is snake oil. Snake oil did actually work on some instances, but it had nothing to do with the snake. There was capsaicin powder that they would often put in the stem cells, and so that would actually give some pain relief for the short period of time. So there may be something in stem cells that we need to research, and I think that research is a good idea, but I don't think the patient should have to pay for the potential of stem cells. I think they should have to pay for the performance of stem cells, which right now is not very good. So I think that the dustbin of history may end up with stem cells in it rather than orthopedic surgeons, but only time will tell where that ends up. So that's as politely as I can discuss stem cells in a public setting. Although surgery is a difficult decision, and there can be consequences to delaying surgery. There was a study at Duke 10 to 15 years ago that showed 88% of patients declined joint replacement when offered. But osteoarthritis is a degenerative disease. It's only going to get worse, unfortunately. There's better outcomes in patients who had their joint replacement earlier in the disease process. So it used to be very common to tell patients to wait as long as you possibly can. And at this point, we try to avoid that. We try to make patients go through and try to do non-operative treatments, but we don't need patients to suffer until they are needing a cane or a walker. We want patients to be able to bounce back a little faster. So patients who had surgery 2 years sooner than those who waited had improved function and reduced pain after the surgery. So if you don't dig yourself such a big hole, it's not quite as hard to dig yourself out of. There's a lot of improvements in arthroplasty, especially in the last 15 to 20 years. 20 years ago, patients stayed in the hospital for 2 weeks. Now patients are going home the same day. We've had improvements in the materials, improvements in the surgical technique, in pain relief, minimally invasive procedures for both surgery and technology, partial and total knee replacements, and new and improved designs. So right now our success rate is 90% at 20 years, and we're thinking that these hips and knees will last 30 years. So that's very positive. One of the benefits that we have from this is from this Mako Robotic Arm. So what is this robotic arm system? What is Mako, and how does it impact the patient's experience in the surgical field? It's computer navigated, robotic arm assisted. We actually have our hands directly in the field. We are in the room. We're standing next to you. I'm not in the corner having coffee. I'm not taking a break. I'm right there running the robotic arm as we go through this process. So we want patients to feel comfortable that we're right there for the process, although the robotic arm does help us for accuracy and being precise. The idea for this started about 15 years ago for doing partial knee replacements. Partial knee replacements are a very technically demanding procedure, but if they're done well, patients are very happy and much happier than patients who have a total knee replacement. But partial knees are usually very specific indications, and so this is where damage and pain is isolated to just one compartment of the knee. 90% of the time that's medial, about 5% of the time it's lateral, and 5% of the time it's just under the kneecap. The idea here is to sort of drill and do a filling like in a tooth rather than doing a crown. So we're a little bit more selective as far as where we do the replacement. So instead of replacing the entire knee, we just replace the inside part of the knee here, maintaining all the patient's normal ligaments and structures and giving them a more normal feeling knee. This can be done for just isolated to under the kneecap, where we can replace under the kneecap and on the trochlea here in the femoral joint. We can also do this in 2/3 knees, where if patients are of very strict indications, we can replace 2/3 of the knee and keep their ACL and PCL intact. We can move these parts independently in computer systems and help our accuracy. The way that this procedure proceeds and how this works, the patient needs to have the correct indications, so you need to have pain in the right area, your x-rays need to match up, physical exam needs to match up. We then get a CT scan of the joint and recreate a personalized 3D model of your specific knee and have that on the computer. Once that model is made, we can then plan for that. So we can plan to 1/10 of a degree or 1/10 of a millimeter and then execute that with accuracy to a millimeter of accuracy. We can maneuver the components in space in any position to fit on the patient that we need. So we don't necessarily make specific implants for the patient, but we have 8 different sizes that we can find to fit exactly for that individual patient. Then bring them back to the operating room. We do place some pins in the thigh bone and shin bone so we can track those bones in space. Then find the center of the hip so we can work from the center of the hip to the center of the knee to the center of the ankle. We go through this process of registering the bone, so we want to build a model of the patient's actual bone to match up to that CT scan. And then we try to verify that model to make sure that we have accuracy. This helps to reduce errors and complications and allows us to be as accurate as we can with each individual patient. Once that's done, it creates a mask which matches up to the patient's native knee. And now those trackers that we've put in place, we can actually follow the knee in space and see our results of the surgery before we've done any sort of bone cutting or committed to anything during the surgery. So we can make some changes with that from that preoperative plan. We can optimize our implant tracking. We can position to optimize cartilage transition zones. And most importantly, we can balance the joint before we do any bone cuts and surgery. So it's an infinitely personalized process that allows us to find out exactly where these parts need to fit on each individual person and then execute that plan precisely. We're able to do it through a minimal incision for less soft tissue damage. We bring in a burr to burr that bone away. The robotic arm creates a safety field for us and a safety room where haptic feedback, which actually increases the resistance the closer we get to the edges and allows us to stay inside the lines. We use this high-speed burr to take away only the bone that's needed to be replaced for the metal, and it won't let us go outside the resection area. So it's safer for patients, it's very accurate. It's an excellent way to take a very difficult procedure in manual instrumentation and make it very consistent and reproducible with the robotic arm. This is a little what that looks like. We create a bed for the metal component to go in. And then this is what it looks like on x-ray. So we're going, take patient's arthritic knee, replace that with a metal and plastic little sandwich over there, but we leave the remainder of the knee intact. So there's more than 70% of the knee that's left behind. And most importantly, the ACL and PCL are left behind. So it's a more normal feeling knee. Patients recover a little quicker because there's less soft tissue damage. And they seem to enjoy the partial knee over a total knee. It's a less invasive, more accurate, very reproducible procedure that's also bone conserving. So if for some reason we do this in younger patients and they do eventually wear this out, 15 to 20 years down the road, we can go back and do a standard total knee replacement. It just preserves options for us moving forward. So we can do this just on the inside of the knee, on the outside of the knee, just under the kneecap, or a combination of the two. Studies have been done, sort of randomized controlled trials comparing robotic arm-assisted Mako partial knees versus manually done total knees of a different company. At 3 months, 57% of patients had an excellent knee society score, and compared to 31% of the patients who were done with manual instrumentation. So almost twice as many patients were happy with the robotic knee as the manual knee. Pain after surgery was less with the robotic arm-assisted knee. It's from 6 days down to 6 weeks from the manual knee. So because we're able to be more accurate and work within the constraints that the robotic system gives us, we're able to do less soft tissue damage and patients can recover quicker. Patient satisfaction in 2 years, vast majority of patients are very satisfied with their partial knee. So patients are doing better because we're doing a better job with the surgery for these partial knees at 2 and 5 years. There's now studies coming out showing 10-year data using this same system with the same implant, showing 99% survivorship and very satisfied patients. So this is very much so helping to reduce a trend. Part of the bad name that partial knees get is a high early revision rate. So if we're not very good as surgeons at doing a surgery, it often fails relatively quickly. So looking at data from the Australian and Swedish registries for manual partial knees, there's almost a 4 to 5% revision rate at 2 years for these partial knees. Compare that to my mentor, Dr. Kuhn, in a large multi-center study showing that it's only 1% at 2 years that needed to have a revision follow-up. And then that 10-year study that's a continuation of this, where it really was just the very few patients early, and 99% of patients currently still are doing well with their partial knees at 10 years. So we now have progressed from doing a partial knee 15 years ago to 5 years ago, proceeding with the Mako total knee. So this was the next step. How can we figure out a way to add this technology for total knee replacement? The goal with any total knee is to replace the end of the femur and tibia with metal and then put a plastic liner in between, and then a little button, plastic buttons placed under the kneecap. The idea here is if this very normal, very healthy knee does become arthritic and wears out the bone and has a lot of inflammation and bone-on-bone pain, irritation, and they failed injections and they failed non-operative treatment, we want to go ahead and replace the end of those bones here with this metal and plastic. So we're just resurfacing the ends of the bone. We're not cutting the bone off at the end of the picture and slamming in an entire big, huge new joint. We're just trying to resurface the ends of the bone and get rid of that arthritis pain. This is what this looks like on x-ray. Left side of the screen, a very normal looking knee, good space between the bones. Right side of the screen, bone on bone, a little bit of bone spurs there, causing some pain and discomfort. And then this is what it looks like once we've gone in and resurfaced and fixed that issue. So we figure out the correct sizing for the bone and resurface the end of the bone with metal and plastic. There is variability similar to partial knees with total knee manual instrumentation, with where we place these rods, how we use these cutting guides, the maneuvering of these cutting guides, and it's not an entirely accurate system. It's very good. We do get patient satisfaction of 80% currently with primary total knees using manual techniques, but our survivorship and the length of time these knees last is at 99%. So what we're trying to do with robotics is not necessarily increase the survivorship, because I think we are doing a very good job of that already with manual instrumentation, but we want to raise the overall patient satisfaction and try to make patients happier with their total knees. It's still not going to be perfect, but we're trying to raise the bar a little bit on that 18% gap that you see. That's where we think that there's a bigger opportunity for patients to be happier with their joints. This is how that system works. So again, we get that CT scan and make the three-dimensional model that's on the computer system. We place the arrays in the knee. We register the bone, so we have that patient-specific bone that we're planning and executing the surgery on. And then we actually go through, and the most important step here is here in the middle. It doesn't involve using the robot, it involves the computer tracking and system, where we can optimize the position of the components for each individual patient to try to balance them in both flexion and extension. And then we can use the robotic arm to execute that plan with safe, consistent bone cuts. This is what it looks like zoomed in, so we can make sure that we have the correct size for the patient. So we can make sure that the size of the femoral component isn't going to be too big, that it's going to be in the right position. Same for the tibial component, make sure that's going to be in the right position, that it's not going to be too big or too small. We can plan our cuts and have sort of a generic plan that we can use. But then when we get into the surgery and we've registered the patient's bone, we can really see how this system looks and works and allows us to actually maneuver those bones in space before we make any bone cuts, so we can find out where these off-the-shelf components need to be positioned to optimize outcomes for each individual patient. This is what that looks like, again, with the arrays in place and registering the bone. Looks like this on the computer screen. So we're confirming our registration, making sure that the information that we gave the robot is accurate. This is the only system that we're able to do this, where we have a image-guided system with that CT scan and building that model for increased accuracy and precision. And then during the surgery, we can actually make sure that there's the correct gap balance on each side of the knee, medial, lateral, in extension and in flexion, and try to make sure that the patient's joints balanced before we commit to these bone cuts. We can make sure that they're equal gaps, equally balanced, and this should give patients better outcomes and more consistent outcomes for each individual patient. Once we finalize the position of those components, we then take this robotic arm. It gets locked into plane, and so we can make these cuts to get rid of the bone. It only allows us to cut the area of bone inside the yellow line there, so it makes it for very precise and accurate. We do that for all 5 cuts for the femoral bone or the thigh bone, and then for the tibial bone as well. So you can see there are very important structures on the north side of this screen back behind the knee, and this system allows us to prevent, allows us very safe execution of the surgery. We can watch the bone being removed, and if we try to go beyond those lines, we'll actually stop the saw and prevent us from cutting things that we don't want to cut. Early clinical results, so this has been out for about 5 years, and we do have some more data coming out, but these are some of the early studies. This compared 3 manual traditional knees versus 3 robotic arm assisted, or sorry, 30 manual knees versus 30 robotic arm assisted knees. The robotic arm assisted knees had a little increase in surgical time, but they actually had less blood loss, used less physical therapy, had less pain than the manual total knees. And by less pain, I thought it might be a statistical anomaly, but the pain score out of 10 for the manual knees was 6.3 at day 1 and 3.6 on day 1 for the robotic knee. So these are still going to hurt. It still is a real surgery, but the pain seems to be less than from the manual total knees. And what we're seeing is patients seem to spend less time in physical therapy, are taking less narcotics, and getting up and rehabilitating faster. We combine this technology with minimally invasive surgical techniques. So Dr. Tom Kuhn was one of the originators of minimally invasive total knee surgery. And so I learned directly from him how to give early and exceptional analgesia, provide that low trauma surgery, and then move for an early discharge and a rapid rehabilitation. So we want patients up and moving. We try to prevent the bad effects before they happen. So we start with some Celebrex, which is an anti-inflammatory to decrease the patient's inflammatory response to the surgery. We do a spinal anesthetic, which helps to reduce complications from blood clots or pneumonias during the surgery, so it's much safer to have the spinal than a general, and then prevent the bad effects from the anesthesia for nausea by trying to calm the stomach with some Pepsid. We make a minimal incision and do injections around the joint. The spinal anesthetic with the IV sedation allows the patients to sleep through the joint, through the procedure, so they don't have to be awake for that. Patients can get up and work with physical therapy, ambulate the same day. So we want patients to get up and move around within hours from surgery. Again, this also helps to reduce blood clots and complications. We do formal gait training, stairs and PT instruction. Like I said, we are having more and more patients go home the same day. Same day discharge isn't for everybody, and we're not going to force you to do it. But many people are able to handle this on their own with family and friends support and feel more comfortable in their own bed after the surgery. Focusing now and moving on to hips and hip arthroplasty and hip replacement. One of the big factors for hip replacement is what the bearing surface is in your hip arthroplasty. I use a ceramic on plastic for my bearing surface. It's a very low wear rate. There was in the last 10, 15 years a big push for metal on metal. A lot of us have moved away from that. The remaining indication for metal on metal is for hip resurfacing, which one of my partners, Dr. Chen, has taken over for Dr. Rector and is doing the hip resurfacing. So if you have an interest in those, I would recommend that you talk with Dr. Chen. I think that the benefits from an anterior approach with robotics outweighs the potential benefits for a resurfacing in almost all patients, although there is a select subset of heavy labor, very young males that may benefit from a resurfacing over a total hip. The reason for that is there is complications from the metal on metal causing issues. Last time I gave this talk, a Grey's Anatomy character had a very serious complication with mental instability from the metal osis that he had in his hip replacement. And so if it became on Grey's Anatomy, it's not really something I want to be involved in, even though I was trained in Seattle. So that's why I don't do hip resurfacings and focus on direct anterior hip replacement with the ceramic on plastic bearing. Why do I do the direct anterior approach, and what is that? It's an approach that's minimally invasive through the front of the hip that allows us good access to the joint and the hip without having to detach any muscles or tendons. It allows us to spread between muscles. It allows us to go between nerves. It's a little bit smaller incision, although you can have similar size incisions for a posterior approach. The posterior, more traditional approaches are on the side of the hip or go to the back, and they do involve having to cut through muscles, having to disrupt the joint and connective tissues from the posterior portion. When we go from the front, we don't have to detach any muscles or tendons, and we can protect those structures as we move through the hip. Why do I do it that way? The hip is actually closer to the front of the body. This is a true surgical plane. That's an intermuscular plane. It's an internervous plane. It allows us to spread between those muscles. We don't have to detach any of the muscles. We don't have to cut through any of the muscles. It's minimal risk to nerves. There is a nerve in the area, but we know where it is and we avoid it. So it's truly minimally invasive surgery, which is beneficial for patients. I think the recovery is a little faster. I think a well-done posterior hip is still a very good surgery, but this allows a few benefits up front and instability long-term for the hip. This is what it looks like for a posterior approach. When we do an anterior, I think there's less pain, quicker restoration of function, usually a shorter hospital stay, and again, we're sending some of these patients home the same day, and all that combines to be probably more economical because patients don't need to take more of the resources. Most patients just do exercise on their own and don't even need any formal physical therapy after the surgery, although there are still patients that benefit from physical therapy after a direct anterior hip replacement. I think it's an ideal soft tissue interval. You are placed onto this torture device here on the left-hand side of the screen. This allows you to position the leg consistently and in space. It allows ease of patient position, so you're just laying on your back instead of your side. And it allows very consistent, simple socket instrumentation, so we can put that cup in the right position. Why doesn't everybody do it this way? It can be unfamiliar territory, and there is a bit of a steep learning curve for physicians who are most familiar with a posterior or a lateral approach. The exposure of the thigh bone can be difficult and does take some time to learn, and it does require some specialized equipment, so you want to make sure you have that available. And it is a bit of a commitment to be able to proceed in learning this technique. How it's done here, we'll kind of give you the overview and then show some videos. We do some special instruments, specialized retractors that give us access to the joint that are a little bit different. They're still very basic and not overly special, but they allow us consistent exposure of the bones. We do need a special light so that we can see into the acetabulum and perform the surgery. And then the special table, I prefer the arch table, which allows us to move the leg in space. It acts as an assistant who never asks for a potty break or a raise, and allows us to consistently do the surgery with subjective information removed and having just objective data used by the patient, by the people who are running the table. So I have information about what's going on with each patient as we do the surgery. So that's why I prefer that arch table over tableless or other table options. This patient's head is at the right-hand side of the screen, their foot's on the left. This is a video of the surgical approach. There's no blood. I know it's dinner time, so this is a very cartooned version of the surgical approach. There's the nerve that we know where it's at and try to avoid. There's a single blood vessel that we coagulate on the way into the joint and into the hip. We know where all of these structures are. We spread down between the muscles down to the joint capsule and expose that. Remove portions of that joint capsule. Oftentimes the joint capsule is very thick and pathologic and really impinges on motion and mobility. That's why patients often have a hard time putting on their shoes and socks or trimming their toenails. Oftentimes stiffness presents before pain in hips actually. So we go in and remove the joint capsule. That exposes the femoral head and the joint. Once we have our exposure from there, we need to go ahead and remove that femoral head. So we go ahead and put a little tools in there to allow us to maneuver that, and then we cut off the end of the bone here to remove that ball and neck portion. I did learn to do this in Napa Valley, so there was extra sort of wine cork removal tools, so we use corkscrews and things of that nature. Once the femoral head is out of the way, then we move over to the acetabular side and prepare for the cup. As you can see, we have excellent visualization of the cup and the position. We remove any of the soft tissue that's in the way, and then freshen the bone with a little bone grater so that we can have the metal cup be placed and the bone can grow onto that metal cup. We then place a plastic liner as our bearing surface so that we have a plastic surface to wear against our eventual ceramic head. And then this is the more difficult portion, which is the exposure of the thigh bone or the femur. So we need to place our retractors in the correct area, and then we have to release the capsule from the superior part of the thigh bone in order to deliver that femoral head up to where it needs to be to safely execute the surgery. We then prepare the bone for the stem that's going to be placed. We find the correct size for the patient via either the CT scan or preoperative templating and knowledge and exactly what size needs to fit in each individual patient. Once the bone has been prepared, we do trial and place practice components in place and then do a reduction of the hip joint so we can test stability and range of motion and make sure that it's the correct implants for that individual patient. So we rebuild that ball that we had previously taken out. Now we need to deliver the femur back into the surgical field, into the joint. We actually don't use that hook, so we need to update the video. You'll see here as the hip comes up, there's going to be some muscles that attach to the inside of the bone there. Those are the muscles that we spare that are cut during a posterior approach, and that's where we have the increased stability from an anterior approach as opposed to a posterior approach. And so this is them moving that arch table to reduce that hip, and now you are all aware of how to do a hip replacement, and I've put myself out of a job. Typical precautions for a traditional hip replacement involve not flexing your knee up past 90, not crossing it over. Often you have to sleep on your back with a pillow between your legs. When we do an anterior approach hip, none of those precautions are needed. We do have one position where we don't want you to bring your leg all the way out to the side and rotate it around and back behind you, but most patients don't do that, so we don't have to worry too much about that position for dislocation. So that helps to avoid a lot of the restrictions that make traditional hip replacement less enjoyable for the patients. I think it's a lot of benefits with minimally invasive surgery for this direct anterior approach. I think it's a shorter hospital stay and quicker rehabilitation, smaller incision and reduced muscle disruption, so they have a quicker recovery time and less scarring. It's not zero scarring, it's still a real incision and real surgery. There's less blood loss. We rarely have to transfuse patients anymore. It's far less than 1% of the time. It's actually a relatively quick surgery, so this takes 40 minutes for the surgery to be done and reduce risk for postoperative pain. We definitely notice that by the low number of narcotics that we have to prescribe. Most patients are fine on Tylenol after the surgery. The risk of dislocation is reduced, so there's less chance that ball can pop out of the cup. And because we're not disrupting the muscles and tendons, it allows for a more natural return for function and activity. I think it's better for the patients. There's definitely fewer hip precautions. We have patients who are definitely getting back to yoga and doing some of those things. Really, we just don't want you to do a full warrior two with that leg behind you and turned out to the side. But besides that, there's really not much that we've seen in yoga positioning that causes a problem. And we have improved control over where we put our components in the surgery. So now we want to combine that soft tissue friendly procedure with some of the technology that we've talked about earlier. So I've been involved with the Mako hip since its inception approximately 10 years ago. And using computer navigation robotic assist gives us an increased level of precision. It gives us confidence in our component position because when patients are done with surgery and getting an x-ray and the post-op, it's too late to make any changes. And we really want to optimize our surgical results during the surgery and not have to worry about what the x-ray looks like after the surgery. Traditional templating is done on a plain x-ray, so we're looking at a two-dimensional image of a three-dimensional structure. When we get a robotic arm-assisted total hip, we get the same 3D CT scan. We can really plan off of the patient's actual anatomy and see what those implants look like in that patient's anatomy. So I think we get better planning off that 3D CT scan. This is a study done comparing the accuracy for placement of cups with manual instrumentation and with robotic arm-assisted total hips. On the left-hand side in that box, there's a lot of scatter points. That's 1,883 total hips that were done, and 47% of those were inside that black box of the target zone. So it was about a coin flip as to whether everything was as accurate as we would desire it for each individual patient. Compare that to 119 total hips that were done with the aid of a surgical robot, and 96% were in the target zone. And actually, some of those that were planned outside of the target zone were still within the plan for the surgery, so 95% within 4 degrees of the plan. So it allows very increased and patient-specific planning and execution of the surgery for placement of that cup. This study was done by one of my partners, mentors, Dr. Dome in Illinois. His whole goal was to try to prove that he didn't need to use a robot. So he had 50 manual hips and 50 robotic arm-assisted hips, and he found that he was good. He was better than the previous slide, where he was 80% accurate with the manual total hips, but he was 100% accurate with the robotic arm-assisted total hips. So he has now moved to doing nearly all robotic arm-assisted total hip replacement. So it really does increase our accuracy, and information that we get from the 3D scan helps us to really dial in what patients need, and allows us to execute that plan precisely. The goals of the surgery remain the same for hips and knees as pain relief and a restoration of lifestyle and function. We are just trying to get rid of the arthritis in the joint. We're not making you 20 again. So it may not feel exactly like it did. It may not feel exactly like the other side, but hopefully it's better than where we started. We want to optimize our patient outcomes and do it in an economic fashion. So we don't want to spend money just to spend money. We want to actually spend money in the correct areas so that we reduce the outlay on the system overall. We again use this early and exceptional analgesia and the low trauma surgery, the techniques that we learned from the total knees, and apply that to the total hips, getting patients up and moving. Preemptive analgesia, Celebrex, and a spinal anesthetic. We're actually also now giving a muscle relaxant before surgery for the total hips, which seems to really decrease the amount of pain that they have immediately after surgery, as well as the anti-nausea for the Pepsid to calm the stomach. We still do that injection around the joint capsule and IV sedation, so patients don't have to hear what's going on in the surgery. This is what it looks like when you have that hip replaced. And again, getting patients up, getting patients moving, and more patients going home the same day, feeling comfortable to care for themselves after the surgery. This is the first patient that I did in Boulder now 8 years ago for his hip replacement. This was him on the left-hand side 4 months after surgery, cresting Teton Pass, and then 4 or 5 months after surgery doing a Century ride. He is a very active individual, but he was in his 80s, so this is a little bit of a Boulder patient cheating, but patients can have very good outcomes with total hips after they get that done. So summary for the total hips, I think the robotic arm total hip is more accurate than the manual total hips, and that's been shown in multiple different studies. We think there's better accuracy with the robotic arm-assisted total hips, with improved clinical outcomes at a year for lower dislocation rate, less change in leg lengths, less blood loss, and excellent patient-reported outcome measures. So patients are doing much better with the robotic arm-assisted total hips. With the robotic arm-assisted total hips, initially it takes a little bit longer OR time. I found that time is now neutral at this point, and there's no increase in infections with the robotic arm. And in fact, we actually think there may be less infection with this because there's less damage to the soft tissues based on how we do the surgery. And so we're looking into making sure this is an economic way to proceed. There are risks with surgery, so I want to make sure that is noted. There are risks of bleeding, infection, damage to nerves and vessels, need for further surgery. There's risk of blood clots going to lungs, and then even rare things like stroke, heart attack, and death. So just want, this is the end of the commercial sort of portion of the drug commercials that you always see where they have to tell you the bad stuff as well. In general, patients do very well with these surgeries, but they still are major surgeries. And since we can't have a talk these days without mentioning COVID, which was mentioned at the beginning of the talk, elective surgeries have been going on at Boulder Community since April of 2020, so we're over a year into this. There's no current plans to stop. Actually, we're busier than we've ever been as far as patients ready to proceed and get these hips and knees replaced and fixed. We do have patients get a COVID test if they're not vaccinated past 2 weeks, and all staff does follow the proper PPE protocol. And so we've been very successful at safely rolling this out with few, if any, complications that I'm aware of. So at this time, I'm going to ask for some questions and see if we can do that.
Absolutely. Thank you, Dr. Blackwood. We have had some questions come in, and I expect several more to roll in, now that you're at the end of your lecture. So, all right, here's the first one, or one I'm going to take first. Can you hear me? Is this
loud
we can
enough?
Hear you. Okay. All right. Dr. Blackwood has done 4,000 hips and knees. How many of those were hips, and what was his infection rate on those?
So I've done more knees than hips. Nationwide, it's about a 4-to-1. I don't have the exact number, but it's a little bit, probably about 60% knees and 40% hips. It works out to be about 150 to 200 hips a year, and 250 to 300 total knees a year. In general, the infection rate's exceedingly low, less than 0.25%. So that's been very successful, and so patients seem to be doing well. Again, nobody's perfect. I'm not saying that I'm perfect. We just try to do everything that we can to optimize outcomes as best we can and reduce the risk to patients as best we can.
Excellent. A guest asks, she says, I'm 73 years old, have osteoporosis, and need a double hip replacement. Am I a good candidate for this type of surgery?
So the patient's asking if they have osteoporosis, how that impacts their surgery. I'd say a large number of patients in my practice are over the age of 65. A large number of them have osteoporosis. We're definitely cognizant of that, and we pay attention to it. It is not unusual, so we're very used to dealing with that. And so we take care to make specific recommendations for patients based on what we find at the time of surgery, and we have options if we need to. If the bone is really bad that we need to even cement the component in place, we can do that. And so really osteoporosis shouldn't eliminate you from a hip or a knee replacement, although we may make some changes to how we fix the implant to the bone.
Excellent. This patient also asks, a guest also asks, but I think it's a very good question for everyone. What is the period of time between the first, if you're having a double hip, what is the period of time between the first surgery and full recovery from the second surgery?
Okay, so how do we sort of separate patients who need to have both sides done? So in general, the data shows us it's about 50% of patients need to have the other side done if they have a hip or a knee replacement, and 10% of those patients need to have either a hip or a knee done if they have their hips and knees done. So it can be very common. There are a number of patients I have that have even had 4 joints replaced. So needing to have more than one is very common. Usually we try to spread those out depending on the patient, their age and health status. If they're very healthy, we can usually do that around 6 weeks in between from the first surgery to the second surgery. If the patient's a little older or need a little bit more recovery time, we try to push that back to maybe 12 weeks, so between a month and a half or 3 months in between surgery. But that's just the soonest that we would do it. Each patient's their own person, so I get some people that are ready to have the other side done 6 weeks later, and some people that want to take some time and be really, really recovered. In general, I tell people that they're going to be about 60% recovered at 6 weeks, 90% at 90 days. But at about a month, most people can walk a mile, ride a bicycle, that kind of thing. Obviously, it's individual patients, and it's an individual patient decision how we proceed with that. But that's kind of the basics of how I make those decisions and move forward.
Question, guest asked, will I lose height as a result of double hip replacement surgery?
Will you lose height as a result of double hip replacement surgery? Usually, patients actually lose a little height with the arthritis and the way that the process goes with losing that space between the joint. So often patients will become mildly taller after the surgery, so we try to restore the hip back to where it's supposed to be. We don't try to change it too much, but it's pretty rare that patients will become shorter after surgery. That almost doesn't happen.
Will a lady be able to wear high heels ever again after hip surgery?
Will you be able to wear high heels ever again after hip surgery? If you wear them now, you should be able to wear them afterwards. There shouldn't be any limitations on shoe wear or anything like that.
Excellent. I'm going to kind of stay with hips for a minute, and then we'll get to some knees. Can this robotic technique work if a total hip replacement needs a resection? Are there implications?
I'm thinking they mean revision, so if they need to have a second hip replacement done. It's not currently on label for that indication to do that surgery. So right now, it's sort of difficult to to proceed with revision surgery with the robotic arm assist. So the official answer is no. Are there places that are using the total hip and working on using the robot for revision total hips? There are. It just isn't mainstream yet or sort of approved for that by the FDA yet.
Thank you. Okay, let's see. To some knees here now. And this probably relates to either hip or knee replacement. I'm 88 years old with a bad heart, but I need a knee replacement. Is this possible?
So with certain health indications, is a possibility to proceed? We try not to say no necessarily to patients unless they have severe comorbidities. So we'd like to talk with the regular doctors, with the cardiologists, to come up with a good plan for that. Again, this isn't a risk-free surgery, but we try to optimize patients as best we can. And so we're trying to come up with as good a plan and understand, based on the risk, whether patients want to proceed. Obviously, no one wants to have a patient not have a successful outcome or not make it through the surgery. Luckily, we haven't had anybody that hasn't made it out of the hospital or had any issues that way. But we would try to be cognizant of the risk factors for each surgery and each individual patient. So we do try to have a team-based approach to coming up with that with anesthesia and the primary care doctor and the cardiologist.
What % of knee surgeries are being done with robotics nationwide?
What % of knee surgeries are being done with robotics nationwide? It's growing. I don't have exact numbers. I know that over half of the Stryker triathlon total knees are now being done with robotics. The number of robots is increasing even just this spring. Or this year, within the last year, there's been robots that put in a Good Sam and up at Longmont United. Was just robots placed in Brighton, out at Poudre Valley, and down in Denver. So it's starting to become very popular. They actually had their biggest year selling robots last year in the middle of a pandemic. So I think it's finally becoming more mainstream. Other companies are developing robots for knee replacement. And so I think the robotics in general is here to stay. I think that the robotic arm-assisted Mako system with Stryker is going to become and maintain its lead as the industry leader and innovator, just because of the benefits that they have and the intellectual property that they have with the CT scan and executing the surgery. So I think it's only going to grow, but I don't have the exact numbers at this point.
I've had anterior, I'm not going to say this right, cruciate ligament repair done on both knees. Do you know what that proper pronunciation is? Okay. How were those previous repairs dealt with during a TKA procedure?
So if a patient's had a previous ACL or anterior cruciate ligament reconstruction, it's actually very common that they then unfortunately need to proceed with total knee replacement. In general, 99.9% of the knees that are done for total knee replacement, the ACL is sacrificed during the procedure. So unfortunately, all of that hard work that was done to recreate that ACL is sacrificed at the time of the surgery in a total knee replacement.
Okay. What are your recommendations for getting both knees replaced at the same time or at different times?
So my recommendations for doing knees at the same time or staging them, I recommend that patients have it staged and spaced, either 6 to 12 weeks in between. I think patients do better recovery-wise, and there's now starting to become some pretty strong data that it's less risk for the patients to have the staged surgery as opposed to having knees replaced at the same time. I understand there are people that do knee replacements at the same time, and I've done it previously, but I'm holding pretty strong that patients do better and have less risk by doing one knee and then going back 6 to 12 weeks later and doing the other side.
Typically, how long does a hip replacement or knee replacement, well, let's do hips first. How long does a hip replacement last?
So typically, but this is the same for hips and knees. So how long do these things last, which is a good question. Data is showing us that there's a 90% chance that the hip and knees will last 20 years. We think there's a good chance that they'll last 30. We're starting to get data out on knees that have been in for 30 years or hips that have been in for 30 years. So there was a lot of surgeons telling their patients, not too long ago that it would expect to last about 10 years. But we're finding out that with the newer techniques and technologies that we're getting much better longevity of these implants. And so we expect 20 to 30 years is sort of the range that we're looking at this point.
Regarding weight, is there a point where you won't do a knee or hip replacement surgery based on someone's weight?
Regarding weight, as far as how that affects the surgery and whether we'll proceed, there are places around Colorado and the country who have a firm cap at 40 BMI where they won't do the surgery and want you to lose weight to get under there. Boulder community doesn't have that at this time, so it's sort of a soft cap. I have had patients come in at 50 or 60 BMI and had some pretty frank discussions, which I probably wasn't very popular for having, where I said that they needed to lose weight in order to proceed safely with the surgery. I have had some very motivated patients who ended up actually losing a significant amount of weight. I had one woman who lost 100 pounds in a year to get down and to have an anterior approach total hip, and another gentleman who lost 60 to 80 pounds in 3 or 4 months and proceeded to have his hip replaced and actually ended up losing a little bit more and having his other side done. So we don't have a firm cap at 40, but we have definite discussions if the patient's above that number.
All right. Let's ask a hip here. Can this robotic technique work if a total hip replacement needs, oh, I already asked that question, please excuse me. A guest is planning bilateral hip surgery in New York City at HSS. Any caution I should be aware of doing 2 and not 1? I'm 71 and in good health.
I mean, it's up to each individual patient as far as doing that. Unless you live in New York, I don't think there's a reason to travel from Colorado to go to HSS to have your surgery done. But they are very good. I know the guys there, and I'm actually trained with some of them for some of these conferences and trainings that we do nationwide for these robotic-assisted surgeries. So tell them hi if you see them. It's up to each individual patient as to how they view that risk-benefit scenario for doing both at the same time versus one at a time.
What is the general cost for these procedures if one does not have insurance?
Good question. So in general, almost everything that I've talked about is covered by insurance as far as what I do. I did mention PRP and stem cells, which I mentioned is not covered by insurance. I did also mention their costs, so I think it's fair to ask this question about what this stuff costs. Usually it's covered by insurance, so usually it takes up people's deductible. And if you have Medicare, it's 80% is covered by Medicare, and then 20% is the rest. If you have a supplement, it usually covers that. For cash pay, it's sort of negotiated between you and the hospital and you and the individual clinic. There are pretty good deals and specials that are set up that you have to talk about. Ballpark, depending on the facility, is somewhere probably between $20,000 and $30,000, depending on how good your negotiating skills are for the entire thing. Of that, mine's about 10% of that cost. So the hospital enjoys my being at the hospital more than I do, I think so.
Mm-hmm. Another question about out-of-state. Wondering if someone comes to Colorado as an out-of-state patient, how do you work that pre- and post-op?
So if a patient does want to come from out of state, and we do get a significant number of people coming from different states. I mentioned I grew up in Montana. I have patients come down from Montana. I've had patients come from many states around the West. We get people that come in from Nebraska and Kansas, and I've had people come from Alaska, Texas. And so usually, and now it's actually easier. One of the benefits from COVID is we can do more telehealth, telemedicine work. So we can actually have a Zoom call meeting where we can do a telehealth evaluation and look at x-rays and have a discussion about what the risks and benefits are and if it's what procedure that you need. And then we can have you set up a time for the surgery with my medical assistant. Once we have that set up, we can just do a pre-op visit the day before the surgery and then proceed with the surgery. Obviously travel is up to you as far as when you head back or how far out of state you are. And then for post-op, we can have you see your primary care doctor at 3 weeks after surgery or kind of show us the scar and incision and make sure things are looking okay. So we can actually do a majority of the follow-up probably with telehealth or from out of state. If you did come back, we'd recommend you come back maybe at 6 weeks or 6 months after surgery, just for another evaluation. But it is amazing how some of this telehealth stuff has impacted some of these travel things. When I was in California and practice at fellowship in my early practice, we had 80% of our patients came from more than 3 hours away, and we had patients come from all up and down the West Coast to have their joints replaced.
What materials are the replacement pieces made of? Do you often see allergic reactions? And do you need to check for metal allergy possibility prior to knee replacement or hip replacement, I suppose?
It's a good question. I mean, what metals are in there and what happens if patients are allergic to metals? In the hips, the metal parts are made of titanium, and there's really not much documented titanium allergy. And then the ceramic head and the plastic liner. So there's really nothing in the hip that people have an allergy to. On the knee side, there's a titanium on the shin bone, the flat piece of metal that goes in. And then on the thigh bone, or that curved piece of metal, is cobalt chrome. In general, that's very well tolerated, but there is a trace amount of nickel in that implant. And some people have an allergy to nickel. And so when people are talking about being allergic to hip or knee replacements, they're worried about nickel seems to be the predominant issue. And so if patients know that they have a metal allergy or metal sensitivity, we can order a test. Unfortunately, it's not covered by insurance, and it's $400 or $500, so it's a blood test. But we can test for all different kinds of metals as well as bone cement before we proceed with that procedure. So that's sort of how we handle that, as sort of on a patient-by-patient basis. If they have some red flags that make us think they might have metal allergies, specifically to nickel, that's where we kind of address. There is some debate about this, even at like big clinics like Mayo in Minnesota, as to how real the allergy is. I think there's enough evidence that it's real that we pay attention to it and deal with it. But it's not real enough that we worry about it to test every single patient for a metal allergy.
I see. Well, are there any unknowns before you make the incision that can complicate things or cause problems?
Are there any unknowns before we make the incision?
Are there known unknowns or unknown unknowns? Or?
In general, we try to eliminate as many unknowns as we can. But until we open up a joint, we can be surprised by some of the things we find in there. It's very rare. Most things we're aware of, but we did have a guy who had green bone, but then he explained to us how he took tetracycline as a kid. So there are some things that may mildly surprise us, but nothing that knocks us over. We're very experienced and have a lot of preparation that goes into these procedures, so we're usually not very nervous as we proceed with the cases.
How far out is your scheduling for surgery right now?
How far out is our scheduling for surgery? So, like I said, it is oddly busy this time of year. We're about a month ahead of where we usually are as far as volume of patients that are getting their hips and knees replaced. We had the busiest April we've ever had. We've had the busiest May we've ever had. I think we're on pace to have probably the busiest June we've ever had. There may be some spots still in July, but even July is starting to get filled up at this point. So while you could be able to come in and see me in clinic, Thursday or next week, the surgery schedule is a little bit further booked out into July at this point.
I see. Are you asleep with a spinal tap?
Are you asleep with a spinal tap? We can sedate you with a spinal tap, and by we I mean the anesthesiologist. So you do often sleep with the spinal tap. You don't have to be, and I've had a handful of patients that have been wide awake throughout the whole surgery, which I don't necessarily recommend, as it sounds much more like a construction site than we like to admit. And so most patients sleep through the surgery after they've had their spinal injection.
Excellent. What is the operative time for knee surgery if hip surgery is 45 minutes?
Okay. So I tell patients, a hip replacement takes about 45 minutes plus or minus. It takes as long as it takes. For knee replacement, the average for a total knee is about 30 to 40 minutes. Everybody's back in the operating room for a little more than an hour. With a partial knee, it's probably 25 to 30 minutes. So they're relatively quick procedures, but that's also because we have a lot of practice and a system that's built to increase that kind of efficiency. We're not racing. It's not a NASCAR pit crew. We're not trying to do it as fast as we can. We're just trying to do it efficiently. That also helps us to reduce our infection rate. So the longer time patients are under anesthesia, the higher the risk for infections and complications is. The longer the incision is open, the higher the risk for infections are. And so by doing a quick, efficient surgery, we're able to reduce those risks.
Excellent. Waiting for a few more questions to come in. At this point, this is the last one we have. A viewer asks, my knee, repaired 3 years ago, swells up sometimes and causes me pain. I'm not overweight. Do you have any suggestions for what I can do?
Sounds like it's probably worth coming in to get an evaluation to sort of see what's maybe going on with that particular knee and see if there's something that needs to be addressed. There are hard parts of arthritis, which we address with the metal and plastic. So the bone on bone is what I'm referring to when I refer to hard parts of arthritis. There's also soft parts of arthritis. So you can have some inflammation or synovitis or irritation from the soft tissues around the joint that can be irritable and unfortunate frustration that can last after surgery. It just sounds like it's probably time for an evaluation.
Are there particular activities you should avoid after hip replacement surgery other than jogging?
It's a good question. So basically I try to have patients avoid running and jumping. I always sort of tell patients not to fall. But in general, patients can get back to activities that they did before their arthritis set in. So hiking, biking, skiing, swimming, elliptical, all that stuff is fine. Swimming, golf, that kind of stuff.
Do all doctors in your group do robotic surgery?
Do all doctors in my group do robotic surgery? The majority of the people who do joint replacement do robotic surgery. So like I said, one of our esteemed partners, Dr. Rector, has retired, and he was actually doing some of the robotic surgery. We've hired new people. So Dr. Chen does robotic hip replacement. Dr. Bowman does robotic hip and knee replacement. Dr. Voss and Dr. Dolbear do robotic hip and knee replacement. I think that's, it's the majority of the group that does hip and knee replacement that still uses robotics. There are a couple that don't, but you just ask the individual surgeon that you're with, and it's okay to switch between surgeons. So if I'm not your cup of tea, there's other options that you have in the practice for those gentlemen that I just listed. Or if you have someone who doesn't and you want to hear more about it, you can talk to me or again my partners who do the robotic joint replacement and get their opinion as well.
All right, I'm going to ask one more question, and if no more come in from our audience, we will begin to wrap up the session here. Are there foods to avoid or any kind of diet or supplements that a person can take to improve their hip and knee bone health, cartilage health? And are there any to avoid or any that you would certainly encourage, pre-surgery?
As far as foods that impact arthritis or inflammation, there's definitely some proponents of different food that can cause inflammation or irritation. There hasn't been any foods that necessarily prevent or reverse arthritis or any of those issues or things. I can't say that there's any proven studies that say any sort of food is better or worse for individuals. Except for sort of calorie count. Obviously the less calories you have, the less weight ends up on your body, which goes across the joints. But as far as inflammation from food, I don't have any great information to share.
What happens to the ACL ligament as a result of total knee replacement?
Okay, this is probably leading off from where I told you that the ACL goes away from a knee replacement. So the function of the ACL is replaced by the design of the implant. And so what the ACL does is stabilize the knee, and it's attached directly in the middle of the shin bone at the top. Unfortunately, we need that top of the shin bone to go away for the knee replacement, and so its attachment point is removed. And so we have to replace its function with the design of the implant.
All right. Did you say that Longmont hospitals do robotic surgery?
I
Longmont
said that there
Hospital?
are definite hospitals in the area that do robotic surgery. We've been doing this here at Boulder Community for the 8 years that I've been here. Do more robotic arm-assisted surgery than every other hospital in the state combined, and have experience going years long in doing this. Not to say that if you're more comfortable at those other facilities, that it's not worth exploring, but there is something to be said for experience and time on the robot outside the learning curve.
Oh, I see. A related question, do you do surgery at any other hospitals besides Boulder?
I do surgery at Boulder Community Hospital and then at the Boulder Surgery Center, which is in the basement of the building where my practice is at. What I found was I did initially do some surgeries at Avista when I came here, but they were not as interested in the robotic arm-assisted surgery, and the patients chose Boulder Community over Avista, who still doesn't, unfortunately, have a robotic system there. And so I have developed a program and a team at Boulder Community Health, which I think is excellent and top-notch anywhere in the country. And so I think that that's the best thing that you have, is to have a facility that supports you and a team that allows you to be consistent in providing patient care.
How can you tell if the problem is initiated from back or hip? Or is that irrelevant if you're certain that osteoarthritis exists in the hip?
I mean, but differentiating between back and hip, and unfortunately it can be both. Usually with x-rays and the physical exam, so we're able to get that information to see what the actual hip looks like, try to move the hip around and see what exactly is causing the pain, and really try to narrow down, is it back, is it hip? That combination usually gives us a good answer.
How are the reference points on the bones made?
How are the reference points on the bones made? So they make that CT scan, and then we have a little probe that has arrays that are seen by a camera. And so what it does is it has the array that's fixed into the bone with those pins that we talked about, and then we use that probe to give points in space. And so what it does is it creates a masks onto the patient's CT scan from the information that you gave it from that rough registration. And then we confirm our registration with those blue bubbles to make sure that we're on bone and have an accurate registration. And so that's how that process is accurate and consistent.
Can you talk about rehab timing and needs?
Talking about rehab timing and needs. So
Needs. I guess the need for rehab and timing for that.
Oh, the need for rehab and time. In general, we have patients do exercises on their own after a knee replacement for the first week, and then start outpatient physical therapy about 7 to 10 days afterwards. Send everybody for a month. Some people need more, some people need less. When we do surgery for the hips, we often have patients do exercises on their own for the first 3 to 6 weeks, and then decide if they need formal therapy at that point.
If you have a neck of femur fracture, is the hip replacement the same as for arthritis?
So if you have a femoral neck fracture, so that's what's often generally referred to as a hip fracture, it depends on the type of fracture. Sometimes they'll fix that with some screws. Sometimes they'll go ahead and do sort of a half a hip replacement where they just replace the ball. And then sometimes we do a total hip replacement based on the situation. So usually patients who have a physician who's familiar with doing hip replacements, they'll just go ahead and do a total hip replacement at that time. If it's not so bad of a fracture, they'll usually try to fix it. And if it's in a patient who has a good cup, but they've broken that ball off in such a way that it's not amenable to fixing, they may do that half a hip replacement because the cup is still in good condition. Or if it's an older patient where they're trying to do a little faster surgery.
I see. At this time, we have 2 more questions, and I'll ask these, and we'll see if some others come in. Are there times when robotic surgeries just aren't the best option for total knee replacement?
Are there times where robotic arm assisted is not necessarily the best option for an individual patient? There can be patients who decline to have the CT scan done because there is an amount of radiation that goes into that. There are certain insurances that don't pay for the CT scan, and so if the patient doesn't want to pay for the CT scan. In general, what I have found is that the information that we get from the CT scan and the robotic arm assisted surgery as we go through there, I think is helpful in executing the surgery and allows us to optimize the surgery. I think patients who have a manual total knee, it can be done as well as a robotic arm assisted total knee, but I think the consistency and the reproducibility of the robotic arm assisted total knee really is something that can't be matched with the manual total knee. So you can have a manual total knee that's as good as a robotic arm assisted total knee, but if you did 20 knee replacements, the majority of them would be better with a robotic arm assisted knee as opposed to a manual total knee.
All right, our last question, unless we have a few more pop in here. Again, it's about diet. Do you believe in a high protein diet prior and post surgery to help with healing? This patient's doctor thought it was too much stress on the liver, but
I don't, like I said, I'm not really a nutritionist or a dietitian, or I'm just a simple Montana boy who grew up on a ranch. So I don't have a great answer. I mean, I eat a lot of protein, but you do need protein for recovery. A high protein diet, you want it to be part of a balanced diet, so you don't necessarily want to do like a straight protein, paleo diet or something like that, or an Atkins diet. You still need, vitamins and nutrients from fruits and vegetables and those sorts of things. So a well-balanced diet, but with some a little bit extra protein would probably be fine, but I don't think you need to necessarily go to a high protein diet.
Are there any other brands besides Stryker, and why do you choose Stryker?
So I choose Stryker. I was using that before the robotics company was purchased by Stryker. I was using the robotics company before it was purchased by Stryker. So for me, it's a no-brainer continuation of the process. So there are obviously other brands that are out there, but I think this is the best combination of technology and implant durability and performance that is currently on the market, and so I think it's the best thing for the patients.
Does a total knee replacement result in some limiting range of motion since the ACL is compromised by the design of the hardware?
Usually the range of motion isn't too affected after surgery. So some patients will start with limited range of motion and they end up increasing their range of motion. If patients have a lot of motion before surgery, it's rare, but they could lose a tiny bit of their motion. In general, patients get the motion back that they had before surgery, usually plus a little bit more. 125 is normal. We often get patients that are beyond that as far as their flexion goes. The goal is always to get their leg to come out straight. And whether it's straight beforehand affects how we design and think about the surgery and execute the surgery. But the ACL has no function in the range of motion for the patients.
Thank you so much, Dr. Blackwood.
Thanks again for having me, and hope everyone has a good night.
Great, thank you. So everyone does thank you. We've gotten lots of thank you notes here for you, and so we have come to the end of our time. A recording of this lecture tonight is available at bch.org/livestream, and you'll receive a post-lecture survey by email. Please take a minute to fill this out. And again, please visit bch.org for information on the COVID-19 vaccination. And thank you so much for joining us. Thank you again so much, Dr. Blackwood. And again, you can review this lecture again on bch.org/livestream. Have a nice night, and we'll see you next week. Appreciate you. Thank you.